Good evening, everybody, and a very warm welcome indeed to this NB Medical Education NB Clinic this evening in partnership with Kidney Research UK. We are talking chronic kidney disease, a call to action. My name is Sarah Davis. I'm a GP from Cardiff with a special interest in diabetes, all things metabolic medicine, cardiovascular disease, and indeed kidney disease as well. I'm going to be presenting the majority of this next hour as we update ourselves on CKD management in primary care. But as always at NB Medical, we welcome your interaction, your questions, your shared learning. So I am joined by my friend and colleague, the fabulous Dr. Rob Walker this evening, who is going to be answering as many of your questions as he possibly can. Good evening, Rob.
Thank you very much, Sarah. Yes, I'd just like to second a very warm welcome from both of us this evening. Really looking forward to this evening clinic on kidney disease. Loads of useful learning points for all of us tonight. Those of you who haven't met me, my name's Rob Walker. I'm a GP down in Basingstoke. I work 3 days a week as a GP and spend the rest of my time with the NB team. But tonight I'll be answering your questions, as Sarah has said. So please do use the Q&A tab down at the bottom there. Please send through any questions, comments, reflections, anything that you think is relevant to this evening's clinic. Please do send them through. I'll do my best to answer them. We're going to be really busy tonight, so I apologise in advance if I can't answer all your questions, but please do send them through and I'll do my best to answer them as we go along. The more the merrier. Sarah, back to you.
Thanks, Rob. Yeah, loads of you joining us this evening. So I'm expecting Rob's going to be super busy over there. Okay, without further ado then, our learning objectives for this next hour. We're going to remind ourselves what the term CVRM means. It's a term that has been bandied around quite a lot over the last few years. Let's remind ourselves what that means and importantly, how CKD fits in to CVR. We're going to look at chronic kidney disease and the burden both for individuals and the system and indeed the inequalities associated with chronic kidney disease. Then we'll touch on some of the new guidelines and the research and current setting for some of our agents, or rather newer agents that we use in chronic kidney disease. So where are we with SGLT2 inhibitors? Finerenone might be a new name to some of us, and potentially even a role for the GLP-1s in CKD. And then what I want to do is really take us back a bit and take a step-by-step guide to optimizing chronic kidney disease care in the primary care setting. And we're going to use a case study to help us think through that. We've got loads of great resources for you to help your primary care delivery of chronic kidney disease care this evening. So if you use the resource list attached to today's webinar, you'll find lots of links there, lots of the guidelines and things that I talk about during this next hour, but also some really useful links from Kidney Research UK. They've got lots of great links for us as healthcare practitioners and lots of useful links for our patients as well. So do have a look at the resource list. And of course, we'll have some great quality improvement ideas for you as always. So CVRM, a term I think we've probably all heard over the last few years. Remember, this stands for cardiovascular-renal-metabolic. And as we can see from that Venn diagram on the right-hand side here, these get stuck together because actually all of these areas, these conditions often coexist in the same individuals, be that metabolic disease, so pre-diabetes, metabolic syndrome, type 2 diabetes, obesity, cardiovascular disease, whether that's atherosclerotic cardiovascular disease or heart failure, and often chronic kidney disease crops up across these conditions. And I'm sure we can all think of many individuals that we look after who have 2 or more of these chronic conditions. And what we often see is that dysfunction in one, for example, heart failure, drives dysfunction in the others, for example, chronic kidney disease. Many people we therefore see living with kidney disease are living with other multiple long-term conditions. This is a cohort study of some UK primary care data from England, published a couple of years ago now, looking at 1,000 people with a CKD code in their notes in England. And quite staggeringly, 96% of those, so the great majority, had at least one other long-term condition. Actually, 9% of this 1,000 people had 6 long-term conditions, the most common of them being hypertension, musculoskeletal, cardiovascular, and diabetes. And it was shown that as people progressed with their chronic kidney disease into stages 3 and 4, so an eGFR below 60, it was much more likely that they also had coexisting cardiovascular disease in 40% of cases and diabetes in 35%. How does this change what we do? Well, I suppose for me, it makes me think about how I'm doing my long-term condition reviews in the practice, and actually thinking about these disease areas as, I suppose, joint entities almost, and certainly considering CKD across them. CKD is a significant burden, both on individuals and the healthcare system. So in the UK, it's estimated that just over 7 million people have CKD. Estimated, of course, because we know it's probably underdiagnosed, of course, entirely asymptomatic, particularly in early stages, and lots of people mooching about with kidney disease that sadly do not know about it. And the numbers are rapidly increasing, particularly as we see increasing numbers of obesity and type 2 diabetes. There are significant personal burdens of living with CKD, and we'll talk about that a little bit on the next slide. But of course, also significant burdens on the healthcare system, such as the NHS. So more people living with CKD is more people ending up needing dialysis, which we know is a huge cost to the NHS, admissions with acute kidney injury, and importantly, an increase in cardiovascular-related complications. We'll talk about it a bit later on. But of course, chronic kidney disease itself is a significant risk factor for cardiovascular events and cardiovascular deaths. There are also important links with inequality and kidney disease. And Kidney Research UK have published a really nice paper reviewing kidney health inequalities. It's been clearly shown that people from higher deprivation are more likely to develop chronic kidney disease in the first place. It's more likely to progress faster. And sadly, they're more likely to have a premature death than people from areas of less deprivation. We also see links with people from minority ethnic communities, again, more susceptible to develop CKD, faster progression. And it's been shown that people from minority ethnic communities are also less likely to receive a renal transplant if and when it is required. The burden of CKD on the individual is perhaps something I haven't given an awful lot of thought to before. Kidney Research UK conducted some interviews of people with lived experience of chronic kidney disease, and a few of the quotes are here on this slide. I think the impact of dialysis is something we can almost all imagine, at least. And I'm sure we've all looked after people who are, getting up in early hours to have to go to the hospital for the day 3 times a week to undergo dialysis. I saw a video actually of a chap being interviewed on a dialysis ward. He'd had long-standing type 2 diabetes and ended up on dialysis. And he was spending sort of 3 days a week there. And I always remember he said in this video, oh, well, I'm here now 3 days a week, and I just feel like my whole life is just whipping past me. And it made me feel really sad, actually. I think the burden of dialysis is not to be underestimated, that's for sure. And some interesting quotes at the bottom here. People felt that they heard about kidney disease, but actually at that time, it didn't seem relevant as it wasn't a current problem. And I suppose for me, it's making sure that we have been clear that kidney disease is a risk, and that we've been, I suppose, had that clarity of conversation with patients. But it is difficult, isn't it? When someone's just diagnosed with type 2 diabetes or with hypertension, trying to have the conversation around the risk of kidney disease is challenging. And again, we're going to touch on that a little bit as we go through. So let's meet our case study for this evening. We're going to kind of weave Vigi throughout this webinar this evening to try and bring to life a little bit of the elements of CKD care that we're talking about. So let's meet her. She's 48 years old. She's been living with type 2 diabetes for 4 years, so diagnosed at 44, had hypertension for some years before that as well, so diagnosed in her late 30s with hypertension. She's on amlodipine, ramipril, metformin, and atorvastatin 20 milligrams. She has come for her annual diabetes review. She's already seen your fabulous healthcare assistant. She had all her numbers and checks done. Now she's come to you to discuss. Blood pressure in the clinic, 145/78. BMI is 31. Her HbA1c is 52 millimoles per mole. That's on her metformin. And you have a look at her kidney results. So you've got her EGFR and her urinary ACR. Her EGFR is 54 with a urinary ACR of 8. Now, of course, what we need to know is what has gone before. So we look back at last year and things are fairly stable. EGFR was 55 then with a UACR of 6. And as you look back over the last few years, you notice, well, there's just been this very gradual decline in EGFR and this sort of little rise in urinary ACR. So she has stage G3A, A2 CKD. If that sounds like foreign language to you, do not panic. I'm going to remind us what that code means just on the next slide. We've also got a lipid profile, total cholesterol 5.2, with an LDL of 3.2. She's busy. She's got 3 teenage children, doesn't get any regular structured exercise, pretty active day to day. She's struggled with her weight all her life. And she's really worried about her kidneys and her diabetes. She's got a strong family history. Her mum's had long-standing type 2 diabetes and hypertension. And actually about 10 months ago, she herself started dialysis. And that has been a massive burden on her mum and indeed on the family as a whole. This is a real priority area for her. So let's remind ourselves first a little bit around the classification of CKD. I know this is not a sort of sexy topic for a Tuesday evening webinar, but it is really important. So remember, we can define chronic kidney disease by someone having a sustained low eGFR below 60 and or a raised urine albumin creatinine ratio above 3 milligrams per millimole. Again, sustained. But really, to accurately code or classify somebody's CKD stage, we need both of those biomarkers. This is the heat map from KDIGO. That's the Chronic Kidney Disease Improving Global Outcomes Group. They produce lots of the big international guidelines around CKD. This is their heat map. We have eGFR along the left-hand side there, from G1 down to G5. And we have urinary ACR across the top, from A1 up to A3. Now, remember that her eGFR is 54, so that puts her at stage G3A, and her urinary ACR is raised at 8, that puts her in the middle column of A2. That's where we get G3A, A2 from, and you can see that pops her in that orangey box in the middle there. Why does it matter? Well, it matters because the hotter your box on the heat map, the higher your risk of progression of your chronic kidney disease towards end-stage renal disease, but also the higher your risk of acute kidney injury, and crucially also the higher your risk of having a cardiovascular event or indeed dying from any cause. And we start to see here from the heat map the importance of urinary ACR. So you can have a normal eGFR or G1 or G2, for example. If your ACR is raised, you're still in those high-risk boxes. So ACR is a really important test, and you can have that normal eGFR but a raised ACR, and you still have chronic kidney disease. Urinary ACR is a really important one. This left-hand graph looks complicated. I know it does, but I really like this because I think it's a really good reminder of the fact that urinary ACR is often the first measurable abnormality that all is not well in a kidney. It's the canary in the coal mine, if you like, that we need to do something and take action. So this shows the typical phenotype development of chronic kidney disease, particularly in type 2 diabetes and hypertension. You see, the first thing that actually goes wrong is that red line, the GFR, actually goes up. That's because in hyperglycemia or hypertension, you have a high blood flow going through the kidney. So actually the filtration rate rises. Of course, we don't measure that. We just get a result that says more than 90 or more than 60. That high pressure causes damage to the glomerular basement membrane, and we start to get protein leaking into the urine. That's when the blue line comes in, ACR starts to rise. And you can see that even actually at an ACR of 3 milligrams per millimole, which would then class as abnormal, there's already almost about 20% nephron mass loss. So time to take action. There was a fabulous publication in Circulation just a few months ago talking about the value of urinary ACR, and that actually albuminuria itself, or a raised ACR, is actually a marker of vascular dysfunction. So while it does warn us that all is not well in a kidney, there's also a warning that across the CVRM system, it's a biomarker that things are progressing and we need to take action. So as soon as we see that raised ACR, we need to think, okay, what can we do to tackle cardiovascular risk, renal risk, and metabolic risk in this individual? Of course, it's not a test we're great at getting done, though. Certainly in type 2 diabetes, urinary ACR is our least well-performed care process, and we're even less good at doing it in hypertension, in patients with existing cardiovascular disease, and so on. I think there's a number of reasons for that. One, certainly here in Wales anyway, is removal from QOF. Love it or hate it, it did get the job done. And certainly we've seen publications from Scotland as well, where removing things like ACR from QOF has led to a significant dip in its completion. But actually, I think one of the big factors is awareness of the value of this test, both by people, by patients, and also by healthcare practitioners and our non-clinical staff in practice as well. I have a fabulous healthcare assistant. She's brilliant. But just a couple of years ago, I heard her in the corridor, and the patient was handing over his urine to her. And he said, "Oh, so Helen, why do you need this test?" And she said, "To check for the glucose in your urine." That's not her fault. That's my fault, because she was made didn't have the necessary education to know the value of getting a urinary ACR done. I think there's a real need here to make sure that our healthcare professionals are aware of the value of this test. Maybe non-clinical staff as well, because often it's the receptionist who are giving out that bottle to try and get the test done, but also, of course, patients. So, for example, now what we do in our practice is that if we're sending out a nudge text to everybody to remind them to get their ACR done, rather than saying, drop in your urine for your kidney test or what have you, we actually say now, remember to drop in your urine test, check your heart and kidney health. Which certainly has a lot more impact, because people are worried about their heart and kidneys and absolutely want to get that test done. Loads of good resources from Kidney Research UK about this, posters for your waiting room and so on, really promoting the value and importance of the test. Of course, sometimes it's practical issues, isn't it? So ideally, we want an early morning sample, but the patient forgets, doesn't bring it in. So my new mantra is any we will do, at least for that initial sample. If that comes back as elevated, we can then repeat the sample on that more sensitive early morning one if needs be. So a lovely bit of quality improvement work is have a look at ways to improve your practice's ACR uptake. Is it those nudge texts talking about heart and kidney health? Is it staff education, non-clinical staff education, or some novel approaches? So maybe involving our community pharmacy colleagues, or thinking about home testing pilots, which are also available to get involved in some areas. Okay, that's ACR. There have been massive changes in the management of CKD over recent years. So we've seen just last year big guideline updates from KDIGO, the Kidney Disease Improving Global Outcomes Group, and also diabetic kidney disease updates from the Association of British Clinical Diabetologists and the UK Kidney Association. That's quite a mouthful. We've had a lot more over the last few years around the role of SGLT2 inhibitors. So we're going to have a little look at where we are with SGLT2 inhibitors and CKD. And finerenone, I think quite new to a lot of us. I don't think really being used hugely widely in primary care in the UK at the moment. But do let Rob know if you are using finerenone. If you don't know about it, we will mention it in a moment. And some exciting brand new data on the potential of GLP-1s here as well. Got to be the hottest group of medications presently, that's for sure. Potential data here in CKD. The message is certainly that there's a lot more that we can do now to slow down progression of kidney disease, to reduce cardiovascular risk, especially early. And that's, of course, when, as always, it's called to primary care to see what we can do to maximise people's outcomes. This is the guideline update from KDIGO. This is a massive international CKD guideline published last year. It's very holistic. It talks about life stage. We're not going to talk about frailty very much today because we haven't got an awful lot of time, but it talks about actually when people become frailer and older, some interventions are not so appropriate when we're thinking about people with limited life expectancy. It also talks about being holistic in terms of lifestyle and the evidence base for lifestyle interventions in CKD. So healthy diet, low sodium, regular exercise, smoking cessation, particularly important in CKD, and weight management as well. There's this rather nice algorithm, there's nice infographics in the guideline actually, talking about first-line therapy and then targeted therapies as necessary. Worth a look. It's a huge guideline, but they've got quite a nice summary, and there's one that's specifically aimed at primary care, actually, if you want to have a little look at this international guideline. Okay, let's look at some of these medications. Before we go to Vigi and take a sort of step-by-step approach to CKD, let's have a little think about where we are with some of these newer medications and their use and their setting in CKD. So SGLT2 inhibitors are gliflozins, of course. It's been really interesting, hasn't it, to watch kind of the story of the SGLT2 inhibitors kind of be told over the last decade, I suppose, really. So initially we were just using them for hyperglycemia, then we had the cardiovascular outcome trials, which means that actually in type 2 diabetes now, according to NICE, we use an SGLT2 inhibitor quite early on in the majority of people to reduce cardiovascular risk. But we also know that they slow the progression of kidney disease and reduce associated cardiovascular risk associated with kidney disease. Initially, we knew that in type 2 diabetes, and now as the evidence has emerged, we now see it outside of type 2 diabetes as well. So where are we? First thing to mention, and I haven't talked about them yet, and we're going to talk about them in our step-by-step, is that this is usually, for most people, in addition to ACE inhibitor or ARB. Remember, for many years, the only thing we could really do to protect kidney disease progression was an ACE inhibitor or an angiotensin receptor blocker. Most of the SGLT2 inhibitor evidence in CKD is in people already on their ACE or the ARB, and we're adding the SGLT2 inhibitor on top. So where are we in people with type 2 diabetes and kidney disease? NICE are quite clear in their kidney disease guideline. As soon as someone's ACR is up and they have type 2 diabetes, we should be adding an SGLT2 inhibitor on top of their maximum tolerated ACE or ARB, certainly if their ACR is greater than 30, and NICE say we should consider it in people with an ACR between 3 and 30 as well. The ABCD UKKA guideline, still a mouthful, even like that, is actually broader and I think a lot simpler. As the evidence base has increased, things do become a bit simpler, don't they? And they actually say we should add an SGLT2 inhibitor for everybody with type 2 diabetes and CKD, so long as their EGFR is greater than 15 when we're starting it. That's anyone with type 2 diabetes with a raised ACR and or a reduced EGFR. We should be actively adding SGLT2 on top of the maximum tolerated ACE or ARB. What about outside of type 2 diabetes? Now, of course, this evidence came from the DAPA CKD and then the EMPA kidney trials, which was the first time they looked at SGLT2 inhibitors in CKD outside of diabetes. There was a lovely publication in the BMJ back in October last year, which I suppose gave that broad recommendations in terms of who should be prioritized and where we should be using SGLT2s in people with kidney disease. And they recommend prescribing them for those adults with CKD at highest risk of progression. And those are three main groups. So those with an EGFR greater than 60, but that highest ACR above 30. Having a high ACR is such an important risk factor for progression of your kidney disease. Also in those people with a reduced EGFR, 30 to 60, but an ACR above 3. And those with the lowest EGFRs, less than 30. In those groups, they recommend prescribing actively SGLT2 inhibitors. And actually, the BMJ did also say consider prescribing in lower risk patients as well, because of the evidence base that we now have. In terms of the exact recommendations, in terms of the NICE technology appraisals for dapagliflozin and empagliflozin, they are slightly different from each other because they're based on the DAPA-CKD and the EMPA-kidney trials. So for dapagliflozin, you can use DAPA for anyone with an EGFR between 25 and 75 if they have type 2 diabetes, or if they have no type 2 diabetes, but their ACR is greater than 22.6. I know it's a ridiculous number, but that's the inclusion criteria they used in the trial, and that's where that comes from in the NICE technology appraisal. The EMPA recommendation is slightly broader because their trial population was slightly broader. So empagliflozin we can use in people with an EGFR between 20 and 45, regardless of their ACR, or in people with an EGFR between 45 and 90, if they have type 2 diabetes, or that ACR above 22.6, a little bit broader for the empagliflozin indication. So quite wide use now, really and truly. In most people with kidney disease of whatever cause here, we can see that SGLT2 inhibitors are likely to be something we should be considering. Now, who knows about this one, though? This might be new to many of you watching, finerenone. Like I say, let Rob know if you are using this in primary care. It has been around for a couple of years, including having a nice TA, but I think in most places remains hospital-initiated or at least specialist recommended. So finerenone is a selective non-steroidal mineralocorticoid receptor antagonist, another mouthful for this evening. So from the same family of MRAs like spironolactone, but that's steroidal. This is a non-steroidal one. So essentially less in the way of side effects such as gynecomastia. The evidence for this came from the Fidelio CKD trial. This was patients who had diabetic kidney disease. So they all had type 2 diabetes and kidney disease with a raised ACR. They compared finerenone to placebo, and they showed an 18% relative risk reduction in the primary composite outcome, which was sustained decline in EGFR, reaching end-stage renal disease, or dying over 2.5 years, which was the number needed to treat of 29 people with finerenone to prevent one of those events occurring. On the back of that trial, we had a NICE technology appraisal for finerenone in March 2023. So we can consider it as an add-on to, wait for it, your ACE inhibitor or your ARB. plus your SGLT2 inhibitor, if tolerated, in people with type 2 diabetes and CKD stage 3 or 4 with an EGFR of greater than 25 and albuminuria. So we're talking here about a patient with diabetic kidney disease who's got an EGFR between 25 and 60, who still has albuminuria. That's the patient where we could potentially add in finerenone. And for me, I have used this now a handful of times. It's specialist advised, I think, here in Cardiff. We have to do advice and guidance to get that go-ahead. In my younger individuals at high risk of progression of kidney disease and indeed cardiovascular risk, those are the patients where I'm considering finerenone as an add-on. A bit like Spiro, potassium can be an issue, so it does need monitoring. Potentially, I think there are some areas using shared local pathways where perhaps specialists are starting and then we're taking over. Do let us know if it's something that you've come across. And finally, in terms of the medicines that we've been looking at over the last few years, what about GLP-1s in diabetes and CKD? So unlike the SGLT2 inhibitors, the GLP-1s have never really shown hard renal benefits. In some of the previous trials, they've shown a reduction in albuminuria, but not that protection in the progression of EGFR that the SGLT2s had shown until now. So hot off the press is the FLOW trial, published in the New England Journal towards the end of last year. It's one of these big trials, 3,500 patients who all had diabetic kidney disease, so type 2 diabetes and CKD. They were randomized to semaglutide injectable, 1 milligram, that's the Ozempic dose, or placebo, and the primary endpoint was very similar to the finerenone trial. They showed a 24% relative risk reduction in that primary outcome in the semaglutide group after 3.5 years. So the conclusion in the New England Journal, semaglutide reduced the risk of clinically important kidney outcomes and death from cardiovascular causes in patients with type 2 diabetes and chronic kidney disease. Now, does this change what we do? Well, it's the first time we've really seen these kind of renal benefits in diabetic kidney disease. We know in other international guidelines, GLP-1s are already used higher up the diabetes treatment pathway than we use them here in the UK, mainly because of cardiovascular risk reduction, particularly atherosclerotic cardiovascular disease. But actually, this is a potential strengthening reason for their earlier use. Interestingly, NICE are currently reviewing their type 2 diabetes guideline, particularly around the positioning of the GLP-1s in the diabetes prescribing pathway. We wait with bated breath, update imminent any week. No doubt we'll be bringing it to you on a blog as soon as it lands. Okay, before we go to Rob on the next slide, I'm going to just take us back because we're going to spend the next sort of 20 minutes after we've gone to Rob for questions to think about a step-by-step guide. Because this can all feel, I think, a bit overwhelming in terms of what do I actually do when I go back to the surgery tomorrow. So I like to see our role in CKD and primary care as fourfold. Number one, detect it. That's screening. We've already talked a little bit about that. Number two is diagnose it and disclose it. So tell our patients about their CKD, what they can do about it, and of course, make sure we've coded in the notes. And then we've got to manage it. And I see the management of CKD really as being a two-pronged approach. Number one, try to delay progression of that kidney disease, so protect the kidneys from further worsening. And number two, reduce that person's cardiovascular risk. We worry, don't we, about people ending up needing dialysis, but actually, when we look at the data, most people, particularly with more advanced CKD, will sadly have a premature cardiovascular death before ever reaching end-stage renal disease. We really want to tackle that cardiovascular risk as much as we can. We're going to take this by using Vigi, our case study, in this kind of step-by-step direction very shortly. But for now, I know there's plenty of questions coming in, Rob. I wonder if you want to draw some of those themes together for us. Thank you.
Thank you very much, Sarah, and thank you all for some wonderful questions here. It's been great. I'll try and pull a few themes out. Apologies I haven't got back to all of you. There's one particular question I think I'd just like a bit of discussion with Sarah about, which is around patients that have got catheters in and how we interpret urinary ACRs with catheters and how we do. I've got a few thoughts around that, but there's not really any sort of really clear-cut guidance. So it's a bit more of a sort of clinical interpretation area, but we'll come back to that in a minute. So let's just go right back to the beginning around CKD. A number of you quite understandably asking, what do we do to diagnose CKD in the first place? What time between tests do we need to do? So just to confirm, you need to have abnormal renal function, whether that be urinary or blood serum levels, 2 tests 3 months apart. So EGFR under 60 or raised urinary ACR on 2 tests 3 months apart, that's when you diagnose CKD. If you see a patient with a new drop in their EGFR or potentially a raised ACR, you just need to do that first initial screen to make sure that it's not an acute kidney injury. We're not going to go into that tonight. We're very much dealing with chronic kidney disease, but 2 tests 3 months apart, then you get your diagnosis. Secondary, a number of colleagues also asking about protein creatinine ratios in the urine. Certainly that was a test we used to do a lot more, wasn't it? These days, most labs will primarily report a urinary ACR. So do generally ask for urinary ACR. Most of the guidance revolves around urine ACRs. However, some labs will still report PCRs, but that's generally when you've got really high protein burdens in the urine. Certainly my lab, they won't do it unless the urinary ACR is over 70. So sometimes you may see PCRs in those situations, but broadly speaking, a urinary ACR is what we should be doing for the vast majority of people now. We'll come back to the catheters in just a minute. Blood pressure targets, Sarah's going to come onto that in a little bit, but one colleague here just flagging up in the KD-IGO algorithm, aiming for systolic blood pressure of 120. Do you follow this target? And if so, at what stage would you? So I think that's a great question, isn't it? Because we generally look at the NICE guidance, which has got much more relaxed targets of 140. So I think for these patients, generally we should be aiming for lower targets. And the phrase I really like to think about these days is something we've talked about in Hot Topics with the hypertension and the European guideline, which is blood pressure should be the lower, the better within reason. So that gives you a bit of clinical sort of space, if depending on the frailty of the patient and those other things. But there's no doubt that most international guidance, particularly for patients with CKD, we should be aiming for those lower blood pressures. And like I say, I think if you want one phrase to just take away for the blood pressure, for me, is the lower the better within reason seems to be a really good way of going about that. Then coming on to that sort of next question here, and Sarah and I were talking about this before we went onto the webinar this evening. We have a lot of patients, elderly, over 85, and we're reminded to deprescribe because of the increased risk of tablet burdens. Yet a lot of these patients have declining kidneys. Many of them should be on statins, ACEs, and SGLT2 inhibitors. Is there any practical guidance in this age group on what to use or to stop? There's no single answer to that because it's got to be dependent on the patient in front of you. Broadly speaking, what you're looking at, I think, is their frailty status. So younger, fitter patients with better life expectancy will benefit from all of those treatments you've mentioned there, ACE inhibitors, SGLT2 inhibitors, statins. Once you get to the frail, elderly 85-year-old patient, you really need to look at what their life expectancy is and what their sort of main problems are. Sarah's going to talk about the 2 sort of facets we're going to look at in terms of slowing progression of kidney disease and then also reducing cardiovascular risk. So which of those treatments you use, indeed, would you use any of them, will be dependent on all of those factors and also the frailty of the patient. The evidence supporting SGLT2 inhibitors is broadly in younger, fitter patients without severe frailty. So an SGLT2 inhibitor may well not be appropriate for your 85-year-old frail patient, but they may well still benefit from a statin and ACE, depending on whether their life expectancy is 5 years, 7 years, 10 years. But it is a difficult one. It's a bit of an individual decision based on the frailty of the patient generally. So Sarah, might just hand back to you then, just for a couple of comments on that frailty issue, the elderly patients. I know we'll with a little bit later, but then also the catheters. So catheters can affect the urinary ACR level. One does need to interpret those with a degree of caution. Ideally, the best way is to get a fresh sample straight through the catheter tube, not out of the bag. And then you might have a base level that you can then at least compare to previous levels. So you're looking for trends. But any thoughts on those 2 issues? Firstly, the sort of the frailer elderly patients in terms of drug treatment, and B, patients with catheters and how we sort of interpret the urinary ACR in those ones.
Yeah, thanks, Robin. Yeah, great, brilliant questions from people. I think you've already said what I wanted to say really around our frailer older individuals. It's all about a little bit of art, I think, in terms of, that individualizing our care. And that's something we're so used to doing in primary care, anyway. You're looking at the person in front of you. What's their level of frailty? What are their wishes? What are families' wishes as well? And some of these interventions that we're talking about are definitely to prolong life in the 5 and 10 year areas. So if you're looking at somebody whose life expectancy is likely to be less than that, then actually it's not going to be appropriate necessarily to be aggressive on their CKD management. It's going to be all about symptomatic control as always. So for those individuals, an SGLT2 just would not be appropriate. I leave people alone. That kind of 89-year-old frail older individual with an EGFR of 55 and a bit of a raised ACR, frankly, I would leave them alone. It's important to know when not to do anything as well to be proactive in primary care, isn't it? That said, if I've got a patient, for example, who's frailer and older and also has heart failure along with their CKD, there an SGLT2 inhibitor might be really useful because we know that they're also indicated in heart failure and actually can have marked symptomatic benefits quite quickly in heart failure with diuretic sparing. And I'm getting more confident about using them in that group, really well tolerated in my own clinical experience. So that's an area where I still might consider it if they had coexisting heart failure in that frailer and older group. And I agree with Rob, really tricky with our catheterized patients to accurately interpret an ACR. I don't think we can safely interpret an ACR in that setting. I agree. If possible, through the tube, ideally, a catheter that's not been very recently inserted, that's sort of, running freely. That's our best bet. And as always, you're going to have to just take the best you've got. So looking at that, but in interpretation with other markers, such as that patient's EGFR. Right, Rob, I'm going to leave you to continue with those while we get through our step-by-step for this next kind of 20 minutes or so. We will be going back to Rob, do not fear, for more questions and answers before we close this evening. So if you remember, we're on our first step of detecting CKD and crucially disclosing it to the individual that is living with it. So we've talked a little bit about screening using both biomarkers, EGFR and ACR. Let's remind ourselves who NICE says should be screened for chronic kidney disease. And I can see there was a question about this. So we know about people with diabetes. We know about people with hypertension. I think we know about people with existing cardiovascular disease on our cardiovascular register, but also not forgetting people with a previous acute kidney injury, people with gout, and people with structural renal disease, hereditary CKD. And it also mentions those with an incidental finding of proteinuria. Potentially a lot of people included in this. And depending where you're at the moment, we might need to start slowly if you're trying to improve your uptake in these patient lists. But that's who NICE recommends regular screening. Certainly, I know that we're quite good at doing it in diabetes in our practice. We need to get better in our patients with hypertension and those with existing cardiovascular disease. That's my mission at the moment. And then we need to tell that individual. And that is something that I know, hands up, I think I've been guilty of not doing well in the past. How many times has someone found out on the NHS app in a printout of their notes that they have CKD stage 3 and they didn't know? For someone like Vigi, you can see how it happens. Their EGFRs here, her EGFRs just started dropping down, but perhaps we weren't proactive about making that diagnosis and sharing it with them. So important we have that conversation. I think it's difficult to have. And actually, when we've been doing the sort of quality improvement work around this in our practice, we really had to sit down and have a clinical meeting with our fabulous, experienced practice nurses to talk about how you would have that conversation around a diagnosis of CKD with an individual. Because I think it can be a bit tricky. And Kidney Research UK have got some great resources to support here. So do have a look on the resource list around the useful links there. Great videos and patient leaflets and so on and so forth. And of course, we can share that evidence for the lifestyle factors that people can start to undertake, so reducing their salt, taking some regular exercise and smoking cessation, really important. So let's go to Vigi. You remember she has got stage G3B-A2. We are going to put the code in the notes. And we chat to her about it. She's worried. Of course she is. She's seen her mum go through it, so she's really anxious. We signpost her to some support. And we also talk about the fact that there are medicine optimizations that we should definitely consider here. Remember, she's not very old. She is at high risk with type 2 diabetes and hypertension, and now CKD. So in heart failure, they've been talking about the 4 pillars for a little while now. And I can see this coming, particularly for diabetes and kidney disease, because we're now in a situation where there's sort of 4 drug therapies you might want to think about for someone like Vigi. So the first one is our RAS inhibition. So your ACE inhibitor or your angiotensin receptor blocker. As soon as her ACR is above 3 in diabetes, you want to be adding that ACE or ARB. and crucially titrating to maximum tolerated dose. There was a lovely publication in Drug and Therapeutics Bulletin just in the last couple of weeks, actually, reminding us that when we start an ACE inhibitor, we should check U's and E's, but an increase in creatinine of up to 30% or a fall in EGFR of up to 25% is acceptable. It's quite decent rises and falls, actually, isn't it? And those are acceptable. Then we're going to offer an SGLT2 inhibitor for many, diabetes or not diabetes, as we've covered already, as per the guidelines. Third pillar in diabetes and kidney disease, we might want to consider finerenone, that non-steroidal MRA that we talked about. And fourth pillar, as we start to see evidence emerging, such as that from the FLOW trial, particularly if someone's HbA1c is over target and they need additional glycemic control, prioritizing a GLP-1. Of course, going to help with weight management as well as glycemic control. And we've got this new evidence demonstrating some protection of the kidneys as well as reduction in cardiovascular risk. So I quite like this four-pillar approach, only because I quite like the idea of trying to remember something this way. And this seems to make perfect sense. Most of our patients ACE SGLT2 inhibitor at the least. So Vigi, you remember, she's only on metformin. She's on a maximum ACE inhibitor. So at this consultation, we're going to talk SGLT2 inhibitor. And remember, her A1C is 52 millimoles per mole. You're quite happy with that in terms of her glycemic control. We're not using it for glycemic control here. We're using it outside of HbA1c for cardio-renal protection. Actually, the conversation with Vigi is not like a glycemic control conversation. Actually, I think it's more like a statin conversation. So I think you should think about this new tablet. We know that it helps to protect your kidneys, protect your heart as well as working a little bit for your diabetes. And that's the kind of conversation we'll be having with her. Remember, when you start an SGLT2 inhibitor, a gliflozin, you get a little drop in EGFR initially. We do not, however, need to check using these like we would with an ACE or ARB. That small drop is expected. Remember that complicated graph near the beginning, that red line of hyperfiltration? This is actually just a little correction in that hyperfiltration. And that's where you get an initial small drop in EGFR. The other little, I think, nugget to remember here is that when you use an SGLT2 inhibitor in people with lower EGFRs, you get little or no effect on HbA1c. Certainly below an EGFR of around 45, no effect at all on A1c. We still should use it and leave it there, crucially. We don't want someone to stop it by accident because it's still giving that cardio-renal protection, even more important, of course, as CKD progresses. But you're not going to get much in the way of glycemic lowering. We have to use something else for that if needs be. And actually, for this reason, I've started recording the indication for the SGLT2 on the notes, because otherwise, a fellow thinking colleague might easily come along and say, well, it's not really done anything for HbA1c. Let's take it out and pop something else back in. But of course, we're using it for a different indication here. So quite useful, I think, pop that into the notes. So that's trying to protect the kidneys from progression. Remember, though, Vigi's at significant cardiovascular risk. I really like this poster from World Kidney Day some years ago now. Protect your kidneys, save your heart. And certainly the links between the two are so important. So we want to be really proactive on cardiovascular risk. Of course, lifestyle intervention, and Rob's already mentioned them, blood pressure targets. What blood pressure should we be aiming for? Nice, relatively relaxed. They say for everybody, including people with type 2 diabetes and CKD, so long as their ACR is less than 70, you should aim for a blood pressure of less than 140/90. Only in people with the highest ACRs, above 70 milligrams per millimole, do they recommend a slightly tighter target of less than 130/80. As we saw from the big KDIGO guidance, they recommend less than 120 systolic unless people are frail or struggling with postural hypotension. That is a low target, isn't it? But evidence-based, and the guideline talks about the evidence for those lower targets. Certainly for me, it's, as always, about individualizing those targets. What we definitely want to do is get everybody with CKD less than 140/90 at least. I know I've got people mooching about with blood pressures above that, just like Vigi, actually. We want to really drive them down as best we possibly can. And perhaps, exactly as KDIGO says, the lower the better here. What about lipid management? So active lipid management, important here too. And nice and clear, in their kidney disease guidance, all patients with CKD stage 3 and below, so EGFR less than 60, should be offered atorvastatin 20 milligrams, and we should be titrating up then to meet targets, whether they're primary or the secondary prevention targets, depending on whether someone has cardiovascular disease. We should be titrating up actively. I think this is quite a nice broad rule. We know that we can use KRUK, of course. In KRUK 3, CKD stage 3 is now included if you're using KRUK 3, although I know it's a bit of a pain to have to use it on the website. But actually, nice and quite clear that everybody with an EGFR of less than 60 is at such significant cardiovascular risk anyway. It's a blanket statin in this group. And the evidence is very clear. There was a lovely Cochrane review back a couple of years ago now, which really reinforced the evidence for statins in this high-risk group. And of course, if someone has type 2 diabetes, we also want to try and optimize their glycemic control if needed. Let's go back to Vigi then. Blood pressure, 145/78. That 145 is definitely too high. I don't know about you, I can feel a bit blasé about blood pressure sometimes, but that one isn't where I want it to be. She's on amlodipine and ramipril. Now that is a clinic reading. I love home blood pressure readings now, don't you? I really like getting those done and looking at that mean of home blood pressure monitoring. I'm using it all the time now. Pretty rare now I do a blood pressure in my room, unless someone's poorly. It might be, though, if she's still elevated on those home readings, that we are going to need to be more proactive around lifestyle measures, of course, and potentially another antihypertensive here. What about lipids? She's on a TORB of 20 already. We've got an LDL of 3.2. Her non-HDL is 3.6. She's a primary prevention patient, so we should be trying to achieve that 40% reduction in non-HDL from baseline. We're going to look back about whether we're there. Unlikely, I suspect, looking at those numbers. Then we want to think about titrating her statin and considering combination therapy for things like ezetimibe to try and reach those lipid targets if we possibly can. What about referral? Does Vigi need referring on to our renal colleagues? Now, I really quite like the NICE criteria for when to refer for chronic kidney disease. I think it's really nice and clear. So, for example, if someone's having a rapid decrease in EGFR of 15 mils or more per year, people with poorly controlled hypertension despite being on 4 agents, and so on and so forth. But the bottom bullet, I think, has probably passed quite a lot of people by, so I think it's worth mentioning. A 5-year risk of needing renal replacement therapy of greater than 5%, bear with me, measured using the 4-variable kidney failure risk equation. What on earth is that? Well, it is a non-invasive risk score, a bit like KRUK and the like, which calculates people's 5-year risk of needing dialysis. And if that's greater than 5%, that would also mean we should get them referred. Probably not integrated into your clinical system. We used to have Vision here in South Wales. So until about 6 weeks ago, when we made the brave move to ENIS, I did have the kidney failure risk equation in Vision that I could just click a button and it calculated it for me. A bit disappointed to see that is not the case on ENIS. Nevertheless, we can go and do it on the separate website. Go to kidneyfailurerisk.co.uk. It's actually really simple. You just need the patient's age, their sex, their EGFR, and their urinary ACR, and it will calculate that 5-year risk of requiring renal replacement therapy for us. So let's do Vigi's. Actually, it's really low, 0.6% chance of needing renal replacement therapy in the next 5 years. So she's low risk, doesn't need referral on to our renal colleagues. It might be that once she's on her ACE and her SGLT2 inhibitor, if she's still got a raised ACR, we might want to think about adding in something like finerenone. So we might want to perhaps get advice and guidance from renal in that scenario. But certainly she can stay under our care in primary care. And as we're seeing today, there is plenty we can be getting on and doing for her. So that's the story of Vigi. That's the step-by-step guide of trying to do the best we can to optimize CKD care. What about some quality improvement ideas then we might want to think about taking back to the practice? Well, of course, there's the big one. And I know in NHS England, you've got a real push to do lots of CKD work at the moment, and it's coming in Wales here as well. So looking at your overall CKD coding is a big undertaking. But I think a worthwhile one, especially in view of the fact there is much more we can optimize now. So searching for your patients with CKD without a code, so an EGFR of less than 60 and or that raised ACR. For those unknown ones to start off with, perhaps, doing the code, speaking to the patient. Now, if there's a lot of patients, is it reasonable to send a letter linking the Kidney Research UK resources and giving an appointment to come for review? It's an interesting one. It's a difficult letter to write, though, so because the conversation is difficult to have when we're talking to people about kidney disease, I think. But the important thing is we need to make sure that people who haven't got that code are coded, and then crucially are informed about their diagnosis. And what we really want to be doing is looking at those medications to slow their kidney disease progression and reduce their cardiovascular risk with appropriate recalls. And I definitely think there's an argument for really integrating this into our long-term condition reviews as part of that CVRM umbrella. A lot of these patients, as we've seen, will be living with type 2 diabetes, obesity, with cardiovascular disease, with heart failure, with hypertension. It makes sense, doesn't it, to do a one-stop shop. But this is a big piece of work, I think, well worthwhile once you're on top of things. And loads of good clinical meetings we can be having to share that knowledge with the other healthcare professionals within the practice. Haven't got quite the time or resource to take that on. Plenty of other ideas we can do. We talked earlier on about ways to improve your ACR pickup rate. What about some other smaller projects? So just searching for your patients who have an ACR of greater than 30. Remember, that's a real high-risk marker for progression of CKD. If you're worried about the numbers, start with your patients with type 2 diabetes. The numbers are not huge. So we're about a 9,000 patient practice. I looked at my patients with type 2 diabetes and that raised ACR above 30. And actually, it was only about 15 or 20 patients. So not a huge undertaking, but a real high-risk group. And I was amazed to find out that they actually were not on optimal guideline-directed therapy. So those patients should be on their ACE or their ARB maximum tolerated dose and an SGLT2 inhibitor as well. So they're a really good group to think about reviewing. And what about active lipid management in our CKD patients? So searching for patients with an eGFR less than 60 that are not on a statin. That's quite an interesting one to think about doing as well. Plenty of loads and loads of QI projects, I think, up for grabs here in CKD. Plenty we can be getting on with. So conclusions, before we go to Rob, plenty of time now for your questions before we close at 9 o'clock tonight. CKD is an important long-term condition. We see it all the time in primary care alongside other long-term conditions, particularly in cardiovascular and metabolic dysfunction as well. And taking a holistic approach to CVRM definitely makes a lot of sense. CKD is a huge burden on individuals and also on the healthcare system, and is an important marker of deprivation, revealing significant inequalities in care. There's so much more we can actively do in early CKD now to identify it early, to reduce progression and risk for individuals. So detecting with screening, disclosing, so telling our patients, having a conversation, signposting to resources, and making that active diagnosis in the notes. And then trying to slow progression of the kidney disease. So we've got this 4-pillar potential approach: ACE inhibitor and SGLT2 for most, and diabetes, finerenone, and maybe prioritizing our GLP-1s in this group as well, and actively reducing that cardiovascular risk, which is really significant and important not to forget about. We don't want to over-focus on kidneys. Cardiovascular risk really important here. Things like the ACE and the SGLT2, finerenone, GLP-1s, they do have an impact on cardiovascular risk, but we also want to think about blood pressure and active lipid management as well. As we mentioned throughout, loads of resources available from Kidney Research UK. They're really keen as an organisation to reach out to primary care to see what we need from them and what they need from us as well. So do reach out to Kidney Research UK and do have a look at some of the fantastic resources that they have available for us. Okay, Rob, we've got, I think, 5-8 minutes or so. I know there's plenty of questions coming in. So should we see what we can get through before we close on time this evening?
Yes, Sarah, brilliant. Loads of fantastic questions. And again, I may bring Sarah in depending on how we go here. So first of all, Sarah has gone through this, but a number of you were just sort of wanting clarification on the statins issue. Are we aiming for secondary lipid prevention for CKD patients? It seems that most patients require more than atorvastatin 20 milligrams to achieve secondary prevention lipid targets. So just to clarify, for patients that don't have cardiovascular disease, we are treating patients with CKD for primary prevention. So we start them at 20 milligrams of atorvastatin, aiming for a 40% reduction in their non-HDL. If they happen to have cardiovascular disease as well, then it's secondary prevention, atorvastatin 80 milligrams, assuming that their eGFR is better than 30, aiming for an LDL of less than 2.0. But I would also very much agree with my colleague here that am I always just starting on 20 milligrams of atorvastatin? I'm not. I'm looking at the overall sort of risk package of patients and where their lipid levels are like. And if they're high risk, I'm actually starting them on 40 milligrams of atorvastatin to try and stop this clinical inertia of just constantly upping their dose when realistically you're thinking they're probably going to need 40 milligrams. So although the guidelines say start at 20, I do not think it's unreasonable to go for higher doses even in primary prevention. Just the caveat being that if their EGFR is under 30, we may just need to take some advice at that stage. We just need to be a little bit more careful about titrating their statins. Great question here, or people talking about assessing the risk for patients with CKD. Do we use Q-risk-3? I mean, it's a good thing to do Q-risk-3. If they've got CKD3, that will be incorporated in their Q-risk-3. But the evidence is very, very clear that if you've got somebody with CKD3, they will benefit from a statin irrespective of their Q-risk. But to be honest, most of them are going to have a Q-risk-3 score of over 10%. So it kind of doesn't matter. But basically, the message is get them on a statin, they will benefit from it. Now, where were we? There were a few other things here. Is it appropriate to use an SGLT2 with catheterized patients due to the increased UTI risk? It is absolutely fine to use in patients with catheters. They're not contraindicated. There is this potential risk of UTI, so we need to be mindful of that. But interestingly, if you look at the RCT evidence, the UTI risk doesn't seem to high as we think. So we probably slightly overplay that. And I don't know, Sarah, do you want to just come in on that point as well? Yeah.
With my diabetes hat on, I agree. Actually, if you look at the evidence, we're worried about recurrent UTIs with these agents early on, but actually it hasn't really borne out in the clinical trials. Where you do see urinary side effects, particularly with kind of polyuria and people feeling that they're weeing all the time, is in people with diabetes, particularly if they have a slightly higher HbA1c. That's when they tend to get more kind of polyuria and urinary side effects. Certainly outside of diabetes, you really don't see that. And certainly in someone like Vijay with that lower A1C, it's unlikely you'd see that as well. So it's not something that particularly would concern me.
Thanks, Sarah. That's really helpful. And there's another cracking question here. Should we worry about the drop in EGFR with ACE inhibitors if the EGFR is already below 30? The simple answer is no. So it's a great question. And there's been some really reassuring data. They've looked at data in this Drugs and Therapeutics Bulletin review that Sarah mentioned. One of the areas they looked at are these patients with lower EGFRs under 30. And reassuringly, ACE inhibitors are still beneficial. So you still may see a drop in their EGFR. And as long as it's less than 25%, that is still absolutely fine. The evidence is fairly clear they will still get their benefit. So don't be put off by that. And in fact, the line from that Drugs and Therapeutics Bulletin, again, I just think is a great line for us all to take away. ACE inhibitors are underused and underdosed. Yeah. So if that's one thing for all of us to take away from this, do the simple things well. Most of these patients are going to benefit from an ACE inhibitor or an ARB. So make sure that we use them and dose them appropriately and don't stop them inappropriately due to drops in EGFR that are less than 25%.
Yeah, what do I think, Rob, with those?
Yeah, absolutely. Do you want to come in on that as well, Sarah?
Yeah. No, I think it's, with that drop is definitely about holding your nerve. I think it's still quite, there's this sort of deep held belief that ACE inhibitors are renally toxic, but actually they are, remember it, renally protective. Even though you see that drop, it's still protecting the kidneys in the longer run. So it's just about holding your nerve. Sometimes easier said than done when we're out in the wilds of primary care though, Rob.
Yeah, absolutely, Sarah. And then there's one final question, which I'm just going to pick up, which is that we can't really give an answer to, but it was a question about whether or not we can extrapolate the results from the GLP-1 agonists that we've got, the FLOW trial, and what about Mounjaro? And the answer is we don't know yet. We haven't got the evidence, but I think we are all suspecting that there will be increasing evidence for both the GLP-1 agonists as well as those combination drugs like Mounjaro that's got the GLP-1 action and the GIP action. They're more potent. They've been shown to be very effective in a number of spheres in cardiovascular disease reduction. So I think we will see them more and more as time goes by. And, if things do happen with more wide access to Mounjaro in primary care, it's an area that we are probably going to have to get more used to dealing with in primary care. I know that's something that NICE are looking at the moment, and they're looking at some patient and clinician aids as well for that. So hopefully to help us along those lines. Sarah, I'll hand back to you. It's very nearly 9 o'clock, but just leave you to do any final clear-ups. But thank you so much for all your questions and time. Been really great. Hope you've learned loads of things. I certainly have over the course of the evening.
Thank you, Rob. Yeah, fantastic. I was just going to say one more final question that I saw about aspirin. So, we sometimes get asked, because these patients are very high risk, would they benefit from aspirin even in primary prevention of cardiovascular disease? And the answer is no. I think it was the ATTACK trial in Southampton, which looked at patients with CKD with or without diabetes. And as we've seen in previous trials in primary prevention, the harms of aspirin still outweighed, the harms of aspirin. Yeah, the harms of aspirin outweighed the benefits. So no routine use of antiplatelets in this group, unless, of course, they've got pre-existing cardiovascular disease. Brilliant, folks. Amazing. So many questions still coming in as well. I hope we've got to as many as we possibly could have done. Your certificate, as you can see on the screen, is available from the menu bar, and it will be uploaded to your NB dashboard account as well. We really appreciate you joining us this evening. We really appreciate our partnership with Kidney Research UK this evening as well. So huge thanks to them, and huge thanks, of course, to Rob, as always. Do just stay for a moment more. When the session finishes, a quick feedback survey will pop up. We really appreciate you just taking a moment to fill that in. It really helps us to develop these sessions and hopefully deliver to you exactly the education that you need to do your job as well as you possibly can in primary care. Thank you, everybody, for watching this evening. Enjoy the rest of your evening, and I look forward to seeing you again very soon.